So I get the opportunity to reflect briefly on these past 2 days as a health services researcher and a clinician and a primary care doctor. And I want to sort of sum up what we've been thinking about. We all know, and we've talked a lot about, how primary care is the foundation of the healthcare system in the US and internationally. We know from a lot of really good evidence that primary care is associated with better outcomes, including better care quality, better patient experience, lower use of ED visits and hospitalizations, reduced spending, including spending on low-value care, and even reduced mortality. Yet, research by my team and others has found that there's been a decline over the past decade or so, and even longer, in primary care visits, which are the building blocks of primary care and the relationships between patients and clinicians historically. So we've looked into why that is, and this findings that it's really multifactorial, right? We have some issues with access to care. We have barriers, both financial in terms of paying for visits. We have capacity constraints. We heard a lot about the maldistribution and inadequacies in the primary care workforce. We've heard about other kinds of barriers, like decreased perceived demand for primary care, or people, especially younger adults, maybe not seeing the need for a continuous primary care provider, but also some maybe positive or neutral shifts that explain this decline in visits, including changes in how we practice. We know from evidence that visits on average are longer. They're packed with more stuff. We're doing more preventive care, talking about more diagnoses during these visits. And there's also shifts to alternative settings and sites of care, and also different ways that we interact with patients beyond that in-office visit. So these trends are concerning. They do speak to the broader worries that we have about the sustainability of primary care despite its importance. And they also suggest ways we can strengthen primary care and its 4 core functions. That's the first contact access to care, coordination of care, continuity of care, as well as comprehensive care, which really underpins the value of primary care and what it can offer. So we've had a chance to dig into some of these solutions over the past few days, and I want to just highlight them briefly here. So the first idea is to make it easier to go to visits, right? To both book them and attend them. That's this idea of reducing the friction of going to visits. That could be through technology like direct scheduling, where patients can book their own visits online, making it easier through transportation services to get to those visits. We heard about things like on-site employee clinics that just create more convenience for patients to get where they need to go. That also means expanding the definition of visits, right? So we've all been using a lot of virtual care, and that should include phone and video visits, as well as secure messaging, while ensuring that we have the capacity and the funding for clinicians to be able to offer those services and the flexibility to make that happen. The next idea is to leverage primary care teams, and we can define that in so many different ways. We heard about the sort of traditional primary care teams, including the role of staff and medical assistants, those who are working at the front desk, nurses, nurse practitioners, and physician assistant colleagues. We can work together to work at top of our licenses to provide good care to patients. That also means expanding the definition, thinking about our behavioral health colleagues, working closely with social workers and psychiatrists, for example, embedded in primary care practices. That might mean working with colleagues to think about social determinants of health and how to take care of that for our patients, and community partnerships. We also learned a lot about investing in communities that have not historically had good access to primary care. And I'll just name some of the many excellent groups that are starting to think about this and described it in our sessions in the past 2 days, including Oak Street, Main Street Health, Unity Healthcare, Urban Health Plan, and Asian Health Services. Really reaching out to specific communities, building trust in those communities, and thinking really holistically and broadly about what they need beyond the traditional offerings of primary care. The next idea, and this really, I think undergirds so much else of what we've talked about, is designing primary care payment to provide clinicians with the infrastructure and flexibility that's needed to provide good primary care. And by that, so many examples I can touch on, but I'll mention, CMS really advocating for these advanced primary care models that offer predictable prospective payments, so that we're not guessing at how much money we have to take care of patients patients, and thinking about moving away most broadly from fee-for-service medicine, which is still the predominant way that primary care clinicians are paid, towards these value-based models that we've been hearing a lot more about. And, for example, also paying clinicians by panel size or using direct primary care as payment mechanisms that allow that flexibility. And finally, we want to ensure that we have the workforce to care for these patients, and that includes so many different steps along the pathway from the beginning. So exposing future clinicians to the joys of primary care, and really investing in people who will stay in their communities, tackling the hidden and explicit criteria or curricula rather in training in medical school and residency and beyond that really discourages future clinicians from practicing primary care. Improving the experience of learning primary care and training in primary care, for example, in residency. So we can, don't give the residents essentially these really rushed experiences where they don't get to experience the joys. And finally, retaining people in primary care. This is so critical, and thinking not just about it, or rather focusing on structural solutions to burnout, for example, like through technology, as we heard about in the last panel, as opposed to individual. Like, we don't need more yoga classes. We really need to focus on making it more of a joy and more easier to take good care of patients. So taken together, there's so much we can do collectively to improve or to really realize the full potential of primary care, and to make sure that value is clear to stakeholders, to the public. So this has been a wonderful opportunity to come together on these issues. I want to thank Primary Care for America and all of our participants today for participating and for inviting me to join. Thank you so much.